We'll go on to the next set. I welcome Dr. Akshaya Ashok for her talk on 2 cases of vascular occlusions. Dr. Akshaya Ashok is at Sunrise Eye Hospital, Kannur. She's a retina consultant at Sunrise in Kannur. Over to you, Akshaya.
Good afternoon, everyone. First of all, I would like to thank Dr. Natasha for giving me this opportunity. So let me start with my cases. This is my first case, which is that of a 45-year-old male who's a known hypertensive who presented to our OPD with complaints of defective vision in the right eye for a period of 1 month. He also mentioned about having some minimal discomfort in the left eye for the past 6 months. He was tested positive for COVID-19 infection 8 months prior to the presentation. On examination, his visual acuity in the right eye was 3 meters and left eye was 6/9. Fundus evaluation showed the presence of inferior BRVO in the right eye with cystoid macular edema. And even in the left eye, there was a superior BRVO, which looked pretty old with resolving hemorrhages. There were no neovascularization. There was a slight temporal pallor of the disc as well in the left eye. So the presence of CME was confirmed on OCT in the right eye. The left eye OCT, the foveal contour was pretty normal with slight irregularity in the inner retinal layers. So considering the younger age group that the patient belonged to and the presence of a bilateral RVO, we did a thorough investigation. We did all the basic blood tests along with vasculitis screening profile, homocysteine levels, antiphospholipid antibody, coagulation profile, cardiology evaluation including carotid Doppler, echo, ECG, but all of which turned out to be normal. So then we proceeded with an intravitreal ranibizumab injection in the right eye, and post-injection, the CME had completely resolved, as you can see in the lower OCT. And then after 2 months, there was a recurrence of CME. There was, with a submacular detachment in the same eye, again, he underwent a second dose of ranibizumab injection, and again, there was a complete resolution of CME. So this is just one simple case of vascular occlusion. Only thing, it was a bilateral vascular occlusion. Moving on to my second case, which is that of an even younger patient, a 34-year-old male, who is an IT professional, who had no known comorbidities, who presented with history of sudden loss of vision in the left eye for 6 hours. He also mentioned about experiencing some blurring in the same eye 2 weeks prior to the presentation, but that day happened to be the day his wife was delivering his baby, so he couldn't pay much attention to the blurring, and he felt it recovered within half an hour or so. And he was tested positive for COVID-19 infection 5 months prior to the presentation, and he was fully vaccinated. The best corrected visual acuity in the right eye was 6/6 and left eye was 660. Anterior segment was normal, there was no RIPD. Right eye fundus was absolutely normal, while left eye fundus examination showed presence of retinal whitening suggestive of a branched retinal artery occlusion. And on OCT, there was an increased thickness of the retinal nerve fiber layer in the left eye, which again is typically seen in artery occlusion. So the patient was pretty worried, so we immediately gave him an ocular massage. AC paracensis was given. We put him on ocular hypotensive agents and immediately sent him for an urgent cardiology and hematology evaluation. And all the possible tests were done, but all of which turned out to be normal again. So he was under frequent follow-up every 2 weeks, and at 2 months follow-up, his visual acuity had improved from 660 to 6/18, and the decrease in retinal nerve fiber layer thickness was noticed in the OCT on the 2 months follow-up OCT. So these are just 2 representative cases that I picked up from the many vascular occlusion cases that presented to our OPD post-COVID, which was notably increased in number, especially in healthy young individuals. So there have been various studies being done on this regard, and this is one of the articles which was published in the International Journal of Retina and Vitreous, published in June 2022, where they reported 14 cases of retinal vascular occlusion within 3 months of lab-confirmed COVID-19 infection, and the mean age of presentation in their report was 48 years. So presentation of vascular occlusion in such young, healthy individuals without any identifiable hypercoagulability risk factors have been attributed to the thromboembolic phenomenon happening in COVID-19 infection. So the three factors said to be involved in the pathogenesis of thromboembolic phenomenon happening in the COVID-19 infected patients are: one is endothelitis, which can cause mechanical obstruction; hyperinflammation and cytokine storm that can activate the clotting mechanism; and again hypoxia, which activates the clotting factors. So my queries to the panelists are, so according to your experience, do you feel the prognosis of post-COVID vascular occlusion is different from the usual cases? And how far does systemic anticoagulants help in retinal vascular occlusion?
Yeah, Akshaya, I think you're right by saying that COVID did see a spurt in patients of vascular blocks. We also observed UCRVOs, arterial blocks, in fact optic neuritis also in a huge number of patients post-COVID. But prognosis-wise, I think they do worse than the other eyes. That's what my experience was. And as far as the role of systemic anticoagulants is concerned, we leave it for the internist to decide, not we. In fact, I never started anticoagulants in any of my patients. So we leave it to the internist or the physician to decide that. They do respond to anti-VEGF as usual. The edema comes down because that is the whole property of anti-VEGF, they will reduce the edema. But recurrences and ultimate prognosis we found to be slightly poorer in COVID patients compared. And that observation is also correct that you see we found a lot of our patients with 30s were very common. Rather than because vascular blocks typically occur post 50 or 60 year age group. So that was my observation. In fact, we found more of CRVOs and optic nerve involvement rather than arterial blocks.
You also published anterior ischemic optic neuropathy following COVID. Did you do a D-dimer assessment for this
D-dimer
patient?
was also done, but that was also normal. So we couldn't point out any cause for this. So the patient is also worried.
But
they are
maybe
in the
because your duration is a little longer from the infection than
yes.
usual.
So we don't know whether this could be attributed to the COVID-19 infection. And one more thing, ma'am, how often should we follow up the patient to see if there are any complications are going to, like neovascularization, anything is going to happen?
I think that you should follow up just as you would do any other vein occlusion. And arterial branch artery occlusion also you have to follow up. So we usually do monthly till the first 6 months and then every 2 months for the first 1 year. And then you can reduce the, extend the duration.
I have one question because I have seen at least 3 cases who developed vein occlusion, but they had features of vasculitis and it was post-vasculitis and it responded to steroids. Instead of giving anti-VEGF, we gave systemic steroid and all the edema and all the hemorrhages resolved completely without anti-VEGF. I have 3 cases. So could you share any experience?
No, you're right because like she pointed out in third last slide, they are inflammatory vascular blocks only. And in some people like she asked about D-dimer, so in some patient hypercoagulability may play a role. But by and large inflammation has a role to play in this. And if they're sick patients, then it's a different matter. But your 2 patients were more of an association rather than a cause and effect relationship. Just being COVID positive does not mean that COVID is contributing or he was vaccinated 5 months back and therefore that is a role to play. That because both these patients were any other vascular block with no specificity that it was COVID. Like what he is saying, 3 patients, they were actually maybe because COVID has a role to play. But in your 2 patients, to me, it looked like they are just coincident history of COVID.
Thank you, Akshaya.